Alright, welcome to part 1 of the respiratory system. I'm having some trouble with my stylus, so bear with me. This is probably like the 15th time I've tried to start this lecture for you guys, but that's alright. We will figure it out. Alright, so the first main function of the respiratory system is shown in this kind of cute picture on the left-hand side, and of course that is gas exchange. And that's the first main function. Oop. Alright, the second main function is pH regulation. Oop. Let's make that a little p. pH regulation. Now, how on earth does your respiratory system allow you to regulate pH? One major way that occurs, the only way really, is that CO2 is exhaled. And CO2 is a volatile acid because it can be exhaled. And so as CO2, which is a weak acid, is exhaled, it allows the pH of the blood to do what? To go more alkaline or go up. Okay. A third main function of the respiratory system is it houses what I think is a pretty important sense, which is olfaction. What is olfaction? Your sense of smell. Alright. Something else that occurs in this space. What else occurs in the nose and in those lymphatic nodules hanging out? Yeah, there's filtration. So, filtration of the inspired air. Is occurring. And this is occurring based on the mucus in and around your nose hairs. And finally, all the beautiful sounds that are coming out of my face is also one of the other things, and that's phonation. So sound production is another. So now we get to the business of why your respiratory system needs to perform gas exchange. Okay, so why do cells need oxygen? Well, the obvious answer, hopefully, is cellular respiration. So what is shown here, and a lot of groovy detail that I'm not going to ask you specifically on an exam for all these enzymes and things, but generally speaking, it's a process by which, so I'm going to try the pen again, nutrients are converted into useful what for the cell? Energy for the cell. Okay, so the general reaction for this process, it can use other nutrients, but the nutrient we most often think of is this is C6H12O6, which hopefully you know is glucose. Requires 6 oxygen, and that's converted into 6 carbon dioxide plus 6 water, and of course this generates what? Yep, that's right, ATP, and lots of it. Notice that oxygen is required. It's kind of hard to see over here. As a final electron acceptor of the electron transport chain. Without it, the whole process stops, and you only get 2 ATP per glucose instead of somewhere between 32 to 38, depending on the cell type and which piece of literature you read. Alright, so now anatomical distinctions. So you can classify the respiratory system based on structure or function. So functionally, what's happening that we're most concerned about is gas exchange. So there's 2 zones based on functional classification, and that is the conducting zone and the respiratory zone. The conducting zone merely moves the air in and out. So this is everything from your nose and your oral cavity through your pharynx, either nasal, oral, and then laryngopharynx, larynx, your trachea, bronchi, bronchioles, and then of course the terminal bronchioles. These are areas where no gas exchange is occurring. Then the other zone is the respiratory zone. This is a site where there is actual gas exchange occurring. This is anywhere from your respiratory bronchioles down, including your alveolar ducts, alveolar sacs, and of course, the main site of gas exchange, your alveoli, the stars of the show. Okay, if you're going to divide up the respiratory structures into structural zones, this is what we discussed in lab, and that is you divide between what is above and below the pharynx. So here's your pharynx. Okay, anything above the pharynx is upper respiratory tract, anything below is lower respiratory tract. And we're going to continue that discussion with a lot of the respiratory tract is lined with cilia, and that cilia helps propel mucus in certain directions, which is where we're going now. So, cilia in the upper respiratory tract, that is above the pharynx or superior to the pharynx, are going to be moving trapped particles of mucus down toward the pharynx, okay? And the cilia in the lower respiratory tract are moving them up. And I want to ask you why. We talked about it in lab, so think about it a second. It's to move towards a location where swallowing can occur, so you can swallow it, which you're doing all the time, taking potential pathogens and letting your super acidic gastric juice deal with it, or if you are sick, you can spit it out and expel it from the body. Here is a scanning electron micrograph down below showing you the cilia that are lining up on top of these epithelial cells. And as I mentioned, probably in laboratory, there is a massive group of epithelial cells all covered with cilia, and those cilia are able to beat together in unison in the direction towards the pharynx. And these cells have an amazing communication ability to allow for that rowing in unison to occur, to have efficient movement of mucus either up or down towards the pharynx. So now to a little anatomy. Your right lung has 3 lobes and your left only has 2. Okay, so there is a superior, middle, and inferior lobe on the right side, and just 2 superior and inferior lobes on the left side. There's a cardiac notch. Guess what is pushing in on the lung right there? Of course, the heart. Okay, so now let's talk about blood flow. So your pulmonary arteries, you should already know what they do. So think about it a second. What do they do? That's right, they carry low oxygen content blood from the heart. Which side? The right side. But that's not the only arteries that are going to the lungs. Okay, you have very muscular walls, a lot of layers of smooth muscle around a lot of your bronchial and your airways. And so there's not enough oxygen to diffuse through that thick layer of tissue. So a second set of bronchial arteries are required to carry what kind of blood? Yep, oxygen-rich blood to perfuse. Perfuse means to allow the fluid to go into, which in this case would be blood, the muscular walls of the bronchioles and the bronchi. Now a quick review from lab. There are pleural membranes, which are analogous to the pericardial sac around the heart. These are serous membranes that surround each lung, and there are 2 pleura. You have the parietal pleura and the visceral pleura, and by now I hope you know that which one is the inner layer. The visceral pleura, and the parietal layer is the one on the outside. So if you come over here, the parietal pleura is the outer membrane, a more superficial membrane. The visceral pleura is the one directly on the lungs. And yep, you guessed it, there is a cavity or a pleural space between these two, which we'll talk about in a second. Well, we'll talk about it now. That's a location where there's reduced friction, just like in the pericardial sac, the serous fluid there reduces friction. Also, it produces surface tension, so there's a stickiness along with the vacuum that exists here to allow maintenance of inflation of the lungs on this space. And as the thoracic cavity expands, the lungs expand with it because these 2 layers stick together. So the parietal is the outer layer, and the visceral pleura is the inner, deeper layer. And again, there's a cavity between them. So branching. Okay, so you can think of the respiratory airways and how they branch as like an upside down tree. Okay, so you start with the trachea as your main conduit of air. Notice the blue rings. This is hyaline cartilage. So this airway is affixed in diameter, which is large, to allow air to move down to this location here, which is called the carina, which, by the way, is where the strongest cough reflex exists, in the carina. That's how you spell it, okay? When this divides the trachea into bronchi, these are the primary bronchi, okay? The right one feeds the right lung, the left one feeds the left lung, so primary bronchi. Okay, when it branches again, those are secondary, then tertiary, etc., down into the bronchioles and the terminal bronchioles, and it keeps going down. There are 25 times this branches, okay? And this is to allow for an incredible amount of surface area. I will do my best to send you another video showing endoscopy videos of the lungs, so you might need to go and refer to another file that I put up to watch any animations and such things, okay? So one thing I want you to notice also is, as we go into smaller and smaller airways, the cartilage seems to just disappear. So now these airways are pretty fixed in diameter. However, all these smaller airways all the way down are encircled in smooth muscle, just like blood vessels are. And so airways are able to be constricted or dilated based on smooth muscle relaxation or contraction. So as I mentioned on the last slide, as we get to smaller and smaller bronchioles, the cartilage rings disappear. They also are non-ciliated, okay? And as the cartilage decreases, smooth muscle increases. And so you guessed it, the ANS is involved in monitoring and affecting the diameter of the airways. Okay, so I want you to think about it a second. What would sympathetic input to the smooth muscle around an airway do to it? Would it cause constriction or dilation, and why? So take a second to think about that. So sympathetic activation would cause relaxation of the smooth muscle, and therefore the airway would dilate. Oop, we'll just say dilate. Okay? Of course, your parasympathetic would do just the opposite. This would cause contraction of the smooth muscle, therefore constriction of your airways. And this makes sense because when you're more active, you want expanded airways to allow for more air to come in for more efficient exchange, and the converse is true when your body is not as active. Something else that can also cause constriction of the vessels through the parasympathetic activation or other things are things like histamine and other allergic reaction mediators. Alright, this should look familiar from lab. This is a lobule of the lung. So this is one unit that is surrounded in elastic connective tissue. This is from a terminal bronchial all the way down. So you go terminal bronchial. Okay. When that comes into a respiratory bronchial, this is where it becomes a respiratory zone functionally. Okay. Then you have alveolar ducts, which break off into alveolar sacs, these large sacs, and each little grape cluster or opening is an alveolus. Notice that these are all continuous and they have openings in each little grape to allow airflow into each little sac. Okay. Something else to notice is that each little alveolus is wrapped in a capillary bed that is fed by a blue vessel that happens to be called a pulmonary arteriole. It's a pulmonary arteriole because arteries bring blood away from the heart. This one's bringing away from the right side, therefore it's blue because it's a little oxygenated, because hello, that's what's happening here. We are picking up oxygen. And that is being returned to the left side of the heart via the pulmonary venule. Also notice there are some green stuff here. This is bringing you back to the last chapter in the lymphatic system. And that's it for that. So let's move on and talk about an alveolus. Okay. The alveolus are those little grape, those cup pouches, all right? You have about 3 million of those cups per your lung, and that gives you the surface of a racquetball court, which I told you in class. It's an incredible thing. Okay, so what we're doing is as we have all those super extended branchings, we are allowing for an incredible amount of surface area. The more surface area you have, the more efficient what is? Diffusion of gases, which is kind of the whole main business of the lungs, okay? In alveolus, we're going to show you some pictures in a second. There are a couple different types of cells. Of course, you should know by now that this is simple squamous epithelial tissue, but just like anything else, we have special names for the epithelial cells that live here. There are type 1 alveolar cells and type 2 alveolar cells. Type 1 are more common. These are your standard epithelial cells that are hanging out. Okay? These cells are where most gas exchange occurs. Okay, these are your standard squamous cells. All right, your type 2 alveolar cells are more rare. They secrete alveolar fluid. So these alveoli only stay open if their little cup is wetted by alveolar fluid, which contains surfactant. And surfactant has to be there to reduce collapsing tendencies of these, and we'll get more into that in a few minutes. But surfactant is a mix of lipoproteins and phospholipids that reduce surface tension. So surfactant reduces surface tension in the alveolar fluid, but it's not gone. In fact, surface tension is an important part of the compliance and kind of recoil of the lungs during exhalation. However, this keeps it in check, so it's just the right amount of tension. So you have a lot of tension there, but not so much that the alveoli collapse. Okay? And then there's one other type of cell there. There's alveolar macrophages that are there for whatever didn't get filtered all the way down to the lungs. So things like fine dust that travel down there, they're macrophages to help deal with it. So let's take a little deeper look at the alveoli. So here are basically the naked alveoli, just showing you the epithelial tissue. Here they are shown with their little web capillary beds wrapped around each alveolus. If you look over here on the right-hand side, this is a scanning electron micrograph showing the actual webbed capillary bed around each individual cup. So this image is a legitimate image from actual scientific pictures. And finally, there is also elastic tissue wrapped around each cup. That, along with the surface tension of the alveolar fluid, allow for great recoil of the lungs to help with exhalation. Here's a section looking down into 1, 2, 3, 4, 5, 6 different alveoli. Here are the type 1 cells. These are just your average simple squamous cells that are super thin to allow gas exchange to occur. Then you have type 2 alveolar cells, which are in green. These are the ones that produce surfactant, which has, and the alveolar fluid. That fluid needs to maintain a thin layer over the entire little cup to keep it open. And then you have your alveolar macrophages. If you zoom in right here, you'll notice here is a capillary, okay? And this is one section, so you can see part of the web capillary around the entire thing. If you zoom in, this is what's called the respiratory membrane, because this is where gas exchange occurs. So here's the alveolar cell, type 1. Here is a squamous cell of the capillary itself, or the endothelial cell. Okay, so there's two simple squamous cells back to back, allowing for a very small distance. So the shorter the distance of diffusion, the more efficient it is. So oxygen can diffuse down its concentration gradient into blood, and CO2 back out. This is something that we didn't talk about as much as I wanted to in the heart, but if there's left side heart failure, which means your left ventricle doesn't eject enough blood, that means there's going to be a backup in the pulmonary circuit. So when there's a backup to the pulmonary circuit, you're going to increase the blood pressure in the pulmonary blood vessels. So when you increase pressure, you're going to have more filtration occurring than normal. So you're going to push fluid from your blood into these spaces. And so this is where potentially how close these are, there could be some edema fluid building up, separating the respiratory membrane, okay, increasing the distance of diffusion, thereby decreasing the efficiency of diffusion, which is why it's really hard for someone. They feel really tired all the time. They feel like they're not breathing well, or their lungs are filled with water, and water's not in this space, but it's here, increasing the diffusion distance of the gases. That is all part of congestive heart failure. Okay, so air and gas exchange can be divided into 3 steps. The first step is ventilation. This is breathing. This is where you have inhalation and exhalation. The next 2 are external or pulmonary respiration and internal tissue respiration. Recall in lab when you hear the term respiration, we're not talking about moving air in and out. We're talking about gas exchange. So external gas exchange is exchange of gases between who and who? The alveoli and blood. Internal or tissue respiration is exchange between. So again, internal respiration is exchange of gases between systemic capillaries and blood and the tissues. Okay, before we explain how air moves in and out of the lungs for exhalation and inhalation, we have to go over Boyle's law. So Boyle's law states that a pressure in a closed container is inversely proportional to the volume of that container. Okay, so on the left-hand side, here you have a certain amount of gas in a closed system, showing you the pressure. In this case, there's a half a liter of volume, and the pressure is 2 atmospheres. Atmosphere is another way to measure pressure, like millimeters of mercury. Okay, so 2 atmospheres. So now, if you pull this piston up, doubling the volume, so the volume is now a liter, you should cut the pressure in half because they are inversely proportional. So now the pressure is 1 atmosphere. So this is exactly what's happening in the lungs. So from here to here, this is what's occurring to allow for reduced pressure inside the lungs to allow air to move in. Okay, more to that, inhalation or inspiration is all about pressure differences. Okay, basically you make your lungs bigger. So inhalation, lungs must expand, increasing lung volume that decreases pressure below atmospheric pressure. And inhalation is always active. In other words, contraction of muscles is required for movement of air inside. Okay, so how's that accomplished? Here we are again. All the steps are listed on the left-hand side, but the main idea is the diaphragm pushes down, and the external intercostals will push the ribs out and up, expanding the full volume of the thoracic cavity. As the lungs are stretched open more as well, you have the same amount of air and now a larger space, decreasing the pressure inside the lungs. When it's lower than that of air on the outside, or atmospheric pressure, air moves down its pressure gradient into the lungs, allowing inhalation to occur. Now exhalation, this is where the pressure in your lungs is greater than atmospheric pressure, then the air runs out. During normal quiet breathing, where you would measure, say, a tidal volume, this is normally passive. So your diaphragm and your external intercostals relax. Okay, so the chest wall does collapse some with the ribs swinging back down, okay, but most of it's based on the elastic recoil of the lungs as well. Okay, so remember all those elastic fibers around the grapes. All right, and then you also have surface tension of that alveolar fluid, which helps with the recoil of the lungs. Again, the alveolar fluid surface tension is reduced by surfactant, but not all the way, to help with this recoil. All right, so now how does this work? So again, the diaphragm pushes back up, the ribs relax back down, all right, and the lungs recoil, decreasing the volume or the size of the lungs, increasing the pressure of the air inside, above that of atmospheric pressure, allowing for air to move out of the lungs and out of the body with an exhalation. So let's go through the respiratory cycle with all this in mind. Okay, so pointer. So when atmospheric pressure is equal to intrapulmonary pressure, which is the pressure inside the lungs, there's 760, there's no airflow in or out because the pressures are equal. Okay, Recall from lab that the intrapleural pressure, this is the pressure inside the pleural cavity between the parietal and visceral pleura, that this is 756, so it's always less than the intrapulmonary pressure, allowing for maintaining of inflation of the lungs. Okay? So now, when we go to take a breath, all right, your ribs swing up like the handle of a bucket. Okay, the external intercostals, raise those, so increasing the size of your thoracic cage. At the same time, your diaphragm pulls down, pulling the lungs down. So the lungs expand both inferiorly and laterally to increase the volume, which decreases the pressure. So now the intrapleural pressure is 6 below atmospheric pressure, and the intrapulmonary pressure is 3 below. So again, this one is still lower than this one. And since the lung pressure is lower than atmospheric pressure, air can flow into the spaces of the lungs with inhalation. Okay? With exhalation or expiration, the diaphragm rises, the rungs of the handle of the bucket go back down, so your ribs go back down. You have the elastic and the surface tension of the alveolar fluid help with recoiling of the lungs, decreasing the volume of the lungs significantly. So the intrapulmonary pressure is now 3 above atmospheric pressure. Okay, because it's higher, it allows air to move back out of the lungs with exhalation. And again, notice that your pleural pressure is still less than your pulmonary pressure, keeping your lungs inflated. So now let me ask you, what happens if your intrapleural pressure becomes equal to or greater than your intrapulmonary pressure? Okay, there's no vacuum, so to speak, right here. Basically, your lungs collapse. Okay, so this can happen with a gunshot wound or stabbing or some other kind of medical affliction. And generally speaking, that requires medical intervention for inflation of the lungs. Again, not always, but most of the time. So I, again, will add this animation to the other file I'll give you so you can see this in a few minutes. Okay, airflow. All right, so airflow is simply getting air in the lungs and out back out, okay? So most of the airflow is based on pressure differences, which we just described, okay? Either moving the intrapulmonary pressure above or below that of atmospheric pressure to allow movement of air in and out, okay? However, there's 3 other factors that affect airflow and ease of ventilation, okay? One is the alveolar fluid surface tension, okay? We did talk about the fact that surfactant reduces this, but it's not absent, okay? We're going to go in more detail in a second on a slide, but basically, this surface tension, when left to its own devices, will allow the alveoli to assume the smallest possible diameter. Of course, the smaller all the alveoli are, the lower the volume in the lungs, okay? So it accounts for about 2/3 of the elastic recoil of the lungs to help facilitate exhalation, okay? Here's that word compliance again. What does compliance again mean? Or mean again? Ability to stretch and recoil. Okay, lungs have to have a super high compliance, which means both the lungs and the chest wall can expand easily. Okay, and it's related to elasticity, not just around each alveolus, but in and around the thoracic cage as well. That's why there's cartilage connecting the ribs to the sternum and not full bone. And of course, surface tension. And finally, there's airway resistance. Okay, this is just like resistance to blood flow. This is resistance to airflow, all right? So generally speaking, your large diameter airways, a large diameter airway has what resistance? It would be low resistance to airflow, therefore would be an issue. Of course, the resistance to airflow is regulated by the diameter of the bronchioles and the lower or smaller airways via which branch of the nervous system, of course. Yep, you guessed it, the ANS, where smooth muscle can either be constricted or contracted or relaxed to either dilate or constrict the airways. And again, what happens if it's sympathetic input? You don't constrict the vessel or the muscle, you force relaxation, which dilates the diameter of the airway, increasing airflow. Okay, so let's go into each part a little bit more specifically. So what is surface tension? Think back to Bio 1 and images of the water bugs walking across the water. Okay, so surface tension is when the liquid molecules themselves are more attracted to one another than the gas at a liquid gas interface. So the water is going to want to interact more with itself than with the gas. Okay. If you look over here, okay, this is an example. This is just a drop of water, okay, on a surface without any surfactant or any other detergents. Okay, notice that the water wants to interact with itself and has very limited interaction with both the gas interface and the surface below. Okay, so there's very poor wetting here. If your alveolus was like this, let's see if I can draw this. Okay, the alveolus would end up being really small, right around that water drop, and that's not really ideal for what we're trying to do here. You don't want teeny tiny alveoli. Okay, what surfactant does is it reduces surface tension, which allows for better wetting. So in this case, the alveolus could be more like this, okay, if it was wetted all the way up here and all the way up here, allowing for a more expanded or open alveolar cup, allowing for greater airflow in, okay. So the alveolar fluid surface tension that's being reduced by surfactant discourages alveolar collapse. Yep, so it discourages alveolar collapse. Okay. If you've ever heard a story about premature birth, one of the main time points you're waiting for is maturation, full maturation of the lungs, where surfactant's being produced. If an infant's born before surfactant is being introduced, the child will not survive without medical intervention, and what usually happens is there's aerosolization of surfactant into the lungs to help facilitate opening of the airways to allow proper exchange. But this means the baby's going to be on a ventilator in the NICU unit. Now a little more detail on lung compliance. Basically, it's a measure of how much stretchability there is in the lungs themselves. It's normally really high because lung tissue is very stretchable, it's distensible. And you also have the alveolar surface tension that once the lungs have been stretched, that allows for great recoil along with the elastic tissue. Of course, there are some things that would decrease this. I don't know if you heard about this before, but sometimes with old age, the costal cartilage can start to ossify, which decreases the flexibility of the thoracic cage. Okay, so if you cannot expand the thoracic cage and reduce it, you have lost some ability for both the lung to expand and the compliance system decreased. Okay, there could be something that interferes with the production of surfactant, either a newborn or some other lung pathology. And then, of course, scar tissue. Scar tissue, as you know, fibrotic tissue is not elastic. So if there's some scarring, either from some severe issue, someone has cancer and has surgery there, anything that would cause fibrotic tissue to be introduced in the place of healthy lung tissue and scarring would decrease the stretchability or the compliance in that location. Alright, air resistance is usually really not a big deal, okay, because you have the really large airways in the first part of the conducting zone of your respiratory tract. And then even though the airways get progressively smaller, there's so much cross-sectional area with the branching that it's really, really minimal. Of course, there is something that will cause a large increase in airway resistance, and of course, what is that? Yep, you guessed it, it's asthma. Okay, so we're going to go over asthma very briefly on the next slide. Okay, so you've increased airway resistance. If you look over here, here's a normal open airway. And this airway, this individual can have either thicker or inflamed walls and or a lot of mucus in there, both of which will decrease the diameter of the airway, increasing airway resistance. And of course, breathing under these conditions becomes more strenuous or more difficult. This can get bad enough in some people that ventilation can completely stop with a really severe acute asthma attack. Okay, also CPR won't work. If the airways are shut, doesn't matter how much you try to blow into the airways, you have to open them back up. So one way to do this is epinephrine. Epinephrine, of course, is a sympathetic molecule that will cause dilation of the airways. Yep. Okay, at this point, we've talked about nothing that's too complicated. Now we're going to get to some more meat on the topic here. So we're going to talk about the concept of ventilation-perfusion coupling. And students have a hard time with this, but if you really think about it, ventilation is the amount of air coming in, perfusion is the amount of blood coming to a location. Okay, so you want these coupled. So ventilation is the amount of air reaching the alveoli, while perfusion is the blood flow reaching the alveoli. And ventilation and perfusion are coupled and must be matched for what? Why do you want to match the air and the blood? Where you'd have good airflow with good blood flow versus maybe bad and bad, okay? This is for efficiency, so it's coupled for efficient gas. You want to have good airflow where you have good blood flow and vice versa. Okay, we're all about efficiency, which is why we can change both blood vessel diameters and airway diameters, all with smooth muscle contraction or dilation. Okay, so in this image we're talking about perfusion adjustment, and of course perfusion is what again? Blood flow. Okay, so I'm going to go to a pointer. Alright, so the stimulus here is you have decreased airflow to a particular location in the lungs, okay? So what is air bringing in that the lungs would want to monitor? Fresh air from outside is going to have a specific quantity of oxygen, okay? So if you have less airflow coming in, you're going to have reduced P oxygen, which is partial pressure of oxygen, which is a way of measuring the concentration of a gas. So if you decrease the amount of oxygen in the blood vessels, what do you want them to do? You have bad airflow, you want to have reduced blood flow. So you have constriction of the pulmonary vessels, decreasing your blood flow, which matches your decreased airflow. Okay? Why on earth do you want to have good blood flow to a region that's not going to bring you a lot of oxygen? It's not going to be very efficient. Okay? Better to divert that blood to a more well-ventilated area of the lungs to pick up more oxygen. Okay? So over here, let's say whatever was causing the decreased airflow, maybe bronchitis one area, you're better now, what have you, there's increased airflow, okay? So now the partial pressure of oxygen increases because you have more air coming in. The blood vessels sense that, which causes them to vasodilate, allowing for increased perfusion, increased blood flow. So you have increased blood flow with increased airflow, again matching good air with good blood. So now before you look at the next slide, I want you to think about the airway adjustments. So in this image, we're talking about blood flow adjustments. However, you already know that the airways themselves can change in diameter as well, okay? So if you're an airway in the lungs, and all of a sudden blood flow to your location has decreased, what could you be sensing? What is coming with that blood from the right side of the heart? It's not oxygen content. We're looking at CO2 levels. Yes, I hope that's what you said. Let's move on to that one. Okay, so now here we have decreased blood flow. So this is probably not going to be as common, but there's decreased blood flow to a region. Okay, so if there's decreased blood flow, less blood is coming down into this area of the lungs, which means there's less CO2. So the partial pressure of CO2 is decreased. If there's not good blood flow, we don't want good air there. So we constrict our bronchioles by causing contraction of the smooth muscle around them, decreasing the airflow to match the decreased blood flow. Okay, let's say this was a temporary issue, and now we've increased our blood flow, so now we have good blood going, good perfusion to an area of the lungs, which is bringing in more CO2. So the partial pressure of CO2, the concentration of CO2 has increased in the alveoli. This triggers the bronchioles to dilate, relaxation of the smooth muscles of the airways, increasing the amount of air coming in to match good blood flow, because you want to bring in good amount of oxygen to this good blood flow to have most efficient exchange. All right, so let's see if you have this. So if you're not sure, go back and listen to the last two slides again, and then come and to remember on this one. Okay, so this is sort of a sum up. So changes in PO2, which again is partial pressure of oxygen. It's a way to measure concentrations of gases. So changes in partial pressure of oxygen in the alveoli cause changes in the diameter of the arterioles, or the blood vessels there. Okay, so let me ask you, if alveolar oxygen is high, what does that mean? Okay, about the airflow. Is the airflow good or is it bad? It's good, y'all. Okay, alveolar oxygen is high, which means you have good ventilation. Okay, so if you have good ventilation, you have good air. What do you want your arterioles to do? You want them to dilate. Of course, now the converse is easy. If alveolar oxygen is low, that means you have low or bad airflow. You want your arterioles to constrict, decreasing the blood flow to match the low airflow. Okay, now conversely, changes in partial pressure in the alveoli cause changes in the diameters of the bronchioles themselves. Okay, so the bronchioles, the airways, are sensitive to partial pressures of CO2 changes based on how well perfused the tissue is. Okay, so now let's go with this one. Now we'll do this one. Alveolar CO2 is high. So what does that mean? Do you have good blood coming or bad blood flow coming? Is it good perfusion or bad perfusion? So if CO2 levels are really high, that means you have a lot of blood or good perfusion of this part of the lungs because there's a lot of CO2 that comes with that blood. So if you have good blood flow, you want good airflow, so your bronchioles will do what? Dilate. Of course, another converse is also easy. If CO2 levels in the alveoli are low, that means there's low blood flow, bringing CO2 to the air, so your bronchioles will want to constrict. Okay, so I'm going to wrap up part 1 here. And I'm sure you just can't wait for part 2. God bless.